Dear colleagues, good evening and welcome to today's cardiology webinar on Do ICDs Still Save Lives in Modern Heart Failure Patients? New learnings from the ESC Congress. I am Professor Leclerc from Rennes University in France, and I have the pleasure of being joined tonight by Dr. Zabel from the Health Center in Göttingen and Professor Dr. Schrage from Karolinska Institute in Stockholm, who will be with us using Skype because of the thunderstorm in Europe. The aim of this webinar is to give you a better understanding of the impact on new data on ICD efficacy for primary prevention of sudden cardiac death in patients with cardiomyopathies, but also to help you to make a decision for the indication of ICD for primary prevention of sudden cardiac death in patients with ischemic and non-ischemic cardiomyopathy in the modern area of medical treatment through clinical case presentations. This session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentations. This program is supported by Medtronic in the form of an educational grant. And now it's my pleasure to hand over to Dr. Zabel for his presentation. Dr. Zabel, thank you for being here.
Professor Leclerc, thank you for your introduction. Dr. Schrage on Skype. Dear colleagues, do ICDs still save lives? These are my disclosures, minor travel grants. And I will speak on effectiveness of ICD therapy in primary prevention, which was the aim of the prospective EUCERT ICD study. The aim of this study was also to look at clinical factors, at subgroups, and determine whether there may be higher or lower benefit in certain groups. But I want to, before presenting this, I want to confront you with a case. Case 1 is an 84-year-old lady with functional class New York Heart 3, so some dyspnea. Her vital signs are not eventful. She has had inferior MI a couple of years ago, and her LV ejection fraction is determined repeatedly under 35, now 33%. As risk factors, she has type 2 diabetes, hypertension, and hyperlipidemia. Her medications include a beta blocker, an ACE inhibitor, a loop diuretic, eplerenone, sacubitril, valsartan, and oral antidiabetics. And multiple choice question number 1 regarding this case is, should this patient receive an ICD for primary prevention of sudden cardiac death? Please punch in your answer. The options are number 1, maybe. She should be reassessed in 3 months for EF. Number 2 is no. Due to the long-standing diabetes, there's no risk of sudden death being significant. Number 3 is no. Due to her older age, competing risks are likely to attenuate the benefit derived from an ICD. Number 4 is yes. Her heart failure medication cannot be efficiently expanded. And number 5 is yes, the patient has symptomatic heart failure with reduced ejection fraction and meets guideline criteria for ICD use.
So, thank you to the audience for answering the question and to choose among one of the 5 proposals. If we look at the guidelines today, everything is very simple. Because for ischemic and non-ischemic cardiomyopathy, you just have to consider the left ventricular ejection fraction. But in clinical practice, we have more questions, and the result of your survey and the survey from Dr. Schrage will be very interesting for us to answer these very practical clinical questions. And if we look at the answer of the audience, it's very interesting that 2/3 of the audience chose the number 5, so the patient has symptomatic heart failure with reduced ejection fraction and meets guideline criteria for ICD use. I must say that I was expecting a little bit more for number 3 due to the older age, only 10%, and 22% decided to vote for number 1, so this patient should be reassessed in 3 months, and if we have a significant improvement in left ventricular ejection fraction, they will not get an ICD. Very interesting question, so now give us some insight about this question.
Yes, I will let you know about the results of the EUCERT ICD prospective study. Actually, this was an investigator-initiated, prospective, controlled, non-randomized, multi-center cohort study. It was being done in 44 clinical centers in 15 EU countries, which you see on the right-hand side. It was coordinated by us at the Heart Center of Göttingen. Enrollment occurred between 2014 and 2018, and follow-up was ended in mid-2019 after that analysis of results and writing up the manuscript. This briefly shows you the parallel design of the study protocol, observational, prospective study protocol. There were 2 groups, ICD group and parallel no ICD group. These 2 groups were non-randomized, observational, and the size of these 2 groups was 2:1. That was demanded by the sample size calculation. Follow-up time averaged 2.4 years in the overall group, somewhat longer in the ICD group because enrollment in the non-ICD group tended to be more difficult and lagged behind for 10 months eventually. Inclusion criteria were, as mentioned, covering the guidelines of the ESC for a Class 1 ICD indication, prophylactically ischemic or dilated cardiomyopathy, LV ejection fraction less than 35% under optimal medical therapy, and age had to be above 18 years. We excluded some important groups. We did not want to dilute the results with a CRT effect, a beneficial CRT effect, so CRTs were excluded, as were previous pacemakers or devices. And we also excluded a limited life expectancy, as the guidelines do as well, and unstable cardiac conditions. Primary endpoint was all-cause mortality. Co-primary endpoints were first appropriate shock, also sudden cardiac death, and some other secondary endpoints I cannot show for the sake of time. This slide shows you the statistical techniques used in this prospective cohort study. I will very briefly go through this. You all know Kaplanmeier curves and Cox regression analyses for corrections. We also used stratification by regions after grouping countries that you saw on the map. We had to adjust for baseline differences, remaining baseline differences between ICD and control group will be shown in a moment, and we used stepwise multivariate models, Cox regression models, as well as propensity score-based techniques. Some are listed here. This was prospectively determined before the start of the study. And these results led to interaction p-values, which are important and will be shown for ICD effect, and important clinical factors such as sex, age, ICM versus DCM, mortality risk group, diabetes, also region. And I already mentioned the sample size, 2:1 ratio for the sake of the statistical power calculation, which yielded 80% power for a 2-sided P, expecting 279 mortality events, which we eventually surpassed. So the study enrolled prospectively 2,327 patients. Some patients had to be taken out for final analysis. Actually, The overall loss here was 80 patients, so as intended, 2,247 patients were analyzable, including 1,516 ICD patients and 731 control patients. So how was the matching the distribution of baseline characteristics between those two non-randomized groups? This is shown on this slide, and because there are so many variables, I can only point out and read out just a few to you. On the right-hand side, the p-value for the comparison. So female patients, 18%, a typical value in such studies with very similar 18.1 versus 18.3. No significance. Age was quite similar, 61.9 versus 63.4. Due to the high number of patients, there was a high significance. Similar for creatinine, low difference but significant. No difference for hemoglobin. Again, a difference, a small difference in LV ejection fraction, 27.5 versus 29.1. These differences still had to be corrected using the statistical methods I've shown. Just one or two more. COPD 11.4 versus 10.4. We were actually quite happy with the distribution, which came out quite naturally and quite matching, such as diabetes 30.2 versus 30.5%. Some other factors had to be somewhat corrected, and important at the bottom, the treatment, the heart failure treatment was very well in all of these patients. ACE inhibitors, beta blockers above 90%. A large number of patients had loop diuretics, actually 70% plus. Also MRAs were given in 78% versus 69%. What were the main results of this study? A lot of the work, I have to say, was done in Eastern Europe, 6 out of 14 recruiting countries, 50% of patients, more than 50% of controls. Most patients had single-chamber ICDs. There were very few crossovers during the study between ICD and control and vice versa. Follow-up was 2.4 years on average, and the mortalities after this follow-up averaged 6.3% per year, which is an overall moderate to low mortality given the overall cohort of heart failure patients. Already you see a difference here. ICD 5.5% per year, control 9.2%. Will be shown on the Kaplanmeier curve in the next slide. The appropriate shock rate, very interesting, around 3% per year, actually 2.8%, so not high, but somewhat significant, adding up to 7% of patients. And these 107 patients had an average of 1.4, 1.5 shocks each. This is the Kaplan-Meier curve over the whole follow-up duration. It nicely shows an unadjusted 32% benefit in ICD patients as compared to control. And it seems so that this difference between the two curves is still growing along the follow-up time. What was this difference due to? What did we have as explanations? Well, we looked into sudden cardiac deaths in numbers. This is not a Kaplan-Meier curve, but a cumulative incidence curve. And we found that the number of sudden cardiac deaths as adjudicated by a committee was much higher in the control group as compared to the ICD group. That explained 2/3 of the effect seen here. Then, and I only have that as a backup slide for the sake of time, then we adjusted the baseline differences. So these curves which are unadjusted, still changed. And one must say that if one superimposed these adjusted curves, they didn't look much different from this curve. But I can tell you that propensity score adjustment led to 32%, 33%, and 34%, and propensity score matching to 41% as compared to the 32% shown here. And the main result using multivariate analysis for adjustment yielded a 27% benefit of ICD versus control. So in summary, on aggregate, there still is in modern treated low to moderate mortality heart failure patients in Europe a clear 27% benefit, which we did not quite expect when starting this. So the second question, this 27% overall benefit is clear. How do the subgroups fare? Elderly, diabetics, ICM versus DCM, mortality, stratified, New York Heart classification. Let's go through this so-called forest plot showing the hazard ratios factor by factor. So the factor age clearly shows what the Danish study also published as a secondary paper. The younger patients benefit much more than elderly patients, and it seems to be that elderly patients do not benefit in our study. The interaction term was almost significant, which is a remarkable result, 0.0902. In diabetics, it was similar. The non-diabetics benefit well. 0.62 is the hazard ratio. The diabetics have 0.945. Again, the interaction term is 0.088, which is remarkable for the sample size and event size. ICM versus DCM was non-conclusive, so we could not compare this group well to the Danish study or derive a difference between ICM and DCM. We clearly showed or found that a low-risk mortality is associated with an improved hazard ratio. This was published before, so it was consistent, but not interacting statistically. The same was true for New York Heart classes. If there was more heart failure, there was a trend for less benefit. I told you a lot of the centers were recruiting in Eastern Europe, so we wanted to see if there was a difference in the effect between Eastern European countries and non-Eastern countries. That was not the case. And finally, sex or gender was something we were interested in at the start. And again, this study showed that women do not seem to derive a benefit from the ICD, but the numbers are too small, 18% of women, and the interaction term is not significant. What are the conclusions from the data I showed you? First, in contemporary ICM-DCM patients with EF less than 35 and narrow QRS, primary prophylactic ICD treatment was associated with a 27% lower mortality after adjustment. There appear to be patients with less survival advantage, such as older patients or diabetics. Number 3, randomized ICD studies are now clearly warranted, and guideline-based ICD indications can become more individualized. This leads me to case 2, also asking you some questions and asking you to punch in your preferred answer. Case 2 is a 62-year-old male with functional class New York Heart 2, so he's doing well. He has had anterior myocardial infarction 8 years earlier. Ejection fraction is 28%, confirmed on repeated measurements. He does have a type 1 diabetes treated with insulin chronically, and heart failure medication consists of beta blocker, ACE inhibitor, eplerenone, and atorvastatin. So question also is, should this patient receive an ICD for primary prevention? Answer number 1, maybe he should be reassessed for another EF. Answer number 2, no. Due to the long-standing diabetes, there's no sufficient risk of sudden death. Answer number 3, yes. Due to his younger age, completing risks are likely to attenuate the benefit derived from an ICD. Number 4, no. His heart failure medication can be expanded. This should reduce the risk of sudden cardiac death. And number 5, yes, the patient has symptomatic heart failure with reduced EF and meets guideline criteria for ICD use.
Thank you, Marcus, for sharing with us the very important data from your registry, because you did show that ICD is efficient to reduce sudden cardiac death, but also total mortality in patients who are treated using guidelines recommended treatments. So I think it was very important to discuss about it. I have a quick question for you. Do you think there is an age limit to implant an ICD?
Well, very good question. Actually, no, because it's a factor which needs some interpretation. Biological age, is the person older than, does he seem older than he actually is, or younger? And we're not, we use 75 years, but it could have been 73 years, 77 years. So it's a factor which determines competing risks and supports this concept, but it has to be individually weighed at the moment.
Another question about this patient. This patient had ACE inhibitors. Before discussing ICD, will you change the ACE inhibitors to Entresto and reassessing the left ventricular ejection fraction? Because we have some data showing that Entresto can increase the left ventricular ejection fraction in some patients.
Also, very good question. I would expect a couple of % from Entresto. If blood pressure allows to administer it, I would do it. But if the patient is 5% away from the 35% threshold, I wouldn't count too long on it. So it is a basis of heart failure treatment, but it does not replace ICDs.
Yeah, even we know that we can decrease sudden cardiac death, we do not delete sudden cardiac death. So the answer for your patient, 71% are for number 5, so they will implant an ICD in this patient, and 15% maybe it should be reassessed in 3 months, probably after changing the medication from ACE inhibitors to Entresto. You have another, I think now you want to ask us after your presentation the first clinical cases?
Exactly. I showed you quite many data that may have some implications on your thinking. So we'd like to reassess case 1. I just read it to you once more quickly. You had punched in your answer earlier. It's an 84-year-old lady, New York Heart 3, post-inferior MI 3 years ago. Ejection fraction is 33% on repeated measurements with diabetes, hypertension, and there is a number of medications consisting of beta blockers, ACE inhibitor, toracimide, eplerenone, Entresto, and oral diabetics. And the question again is, should this patient receive an ICD? Number 1 was maybe, we reassess EF after 3 months. Number 2 was no. Due to the long-standing diabetes, no risk of sudden death. Number 3 is no. Due to the older age, competing risks are likely to attenuate the benefit. Number 4 is yes. Her heart failure medication cannot be expanded. Number 5 is yes. Patient has symptomatic heart failure with reduced ejection fraction and meets guideline criteria for ICD use. Please.
So thank you for voting again. Marcus, I have some question about your study because we did not discuss about inappropriate shock or complication of ICD. Can you give us some insight about your study during this follow-up time of 2.5 years, more or less?
Yes, we also collected data about what you just mentioned. Inappropriate shocks were below 1%, actually 0.9%, which was very reassuring to us in a real-life study with programming demanded to be modern and effective. And re-interventions, dislocations, or infections averaged 3% per year. So that's a number still below 10%. It's more than zero. It does happen. But the rate is also within what we had hoped for. And it should be assessed when thinking about the indication that there are some re-interventions and operations in some patients.
So I think you are very convincing because we have for number 5, 10% more of the attendees. We decided to vote for number 5. So now we are 70% of the audience decided to implant an ICD in this patient who is not so young. I have another question for you. It's we use left ventricular ejection fraction in our guidelines, but do you think we can use something else to improve the selection of the patient who can benefit from ICD?
Well, yes, actually, yes. And one may start with New York Heart Functional State, which is already included in the guidelines. New York Heart 1 requires less ejection fraction to qualify. Then one would choose age, of course, as a relative factor. One may choose or discuss or involve mortality risk score, involving diabetes and other factors. But of course, it has to be discussed which factors to choose, and so that's open for discussion from our data, from other data, from the literature.
Yeah, thank you, and we will discuss about the potential role of imaging technique with Benedict. So thank you for sharing with us. You stay with us, and we will have a common discussion later on. So now it's my great pleasure to welcome on Skype Benedict Skrager from Sweden. So he will present us the result of his registry performed in Sweden. So thank you for being with us.
Dear Professor Zabel and dear colleagues, thank you so much for having me on this webinar. And although I would very much prefer to be in Paris right now with you instead of being stuck in a thunderstorm, I'm glad to proceed now with the second case of the day. Regarding my conflicts of interest, I do not have a conflict of interest in regard to this presentation. However, the study, which I will present later, was funded by Boston Scientific and by a grant from the European Union Big Data at Hearts project. So the aim of this case presentation is to discuss in detail the use of ICDs for the primary prevention of sudden cardiac death in a contemporary treated heart failure patient. So let's directly jump to the case. The case is about a 70-year-old male patient who is hospitalized for dyspnea. He presented with shortness of breath, peripheral edema, and autopnea. His blood pressure is elevated at about 150 millimeter mercury. The heart rate is in the upper limit of normal. He has a history of arterial hypertension and is on treatment with amlodipine. In the echocardiography, which you see on the next slide, severely reduced left ventricular ejection fraction is revealed, as well as a dilated left ventricle. The patient also has wall motion abnormalities, most importantly an akinetic region in the basolateral segment, which might be indicative of scar tissue. On the next slide, you see that we performed the full diagnostic workup in this patient, who was then diagnosed with heart failure neuroclass 3 due to ischemic cardiomyopathy. There was no indication for PCI or CABG, but aside from the previously known arterial hypertension and coronary artery disease, no other comorbidities were revealed. We then started this patient on intravenous diuretics for decongestion and initiated guideline-recommended heart failure therapy. Later, after successful decongestion, the patient was discharged from home. You will then see on the next slide that after 4 months, the patient represented to our outpatient heart failure clinic for a follow-up assessment. Since the initial presentation, his symptoms have improved, and he now has an adequate activity in daily life, although still being symptomatic in neuroclass 2. His blood pressure is no longer elevated, but well controlled, and he's now on optimal heart failure medication with beta blockers, ARNIs, and MRA. Ejection fraction has also slightly improved, but due to a relatively small QRS complex, without a favorable morphology, he does not have an indication for CRT. So my question to the audience is, and that you can see on the next slide, should we treat this patient with an ICD? So should he maybe get an ICD after reassessment after an additional 3 months to see if his ejection fraction improves to above 35%? Or should we maybe perform a cardiac MRI to identify or not identify a substrate for malignant arrhythmias? Third, should he not receive an ICD as he might be too old and competing risks will most likely attenuate his ICD benefit? Or should he not receive an ICD because his heart failure medication is so good that it minimizes the background risk of sudden cardiac death? And the fifth option should be that this patient might need an ICD because he meets all guideline criteria for it. I'm now quite excited to see what the audience thinks about this.
Yeah, thank you to the audience to vote and to choose one of these options. In the registry presented by Marcus, I saw that the majority of ICD were single-chamber ICD, and we have among the great number of questions we have from the audience, do you think that there is still a role for dual-chamber ICD in patient in sinus rhythm?
I think this depends, as always, a bit on the patient. If it would be a patient with a very high risk to develop or maybe having undetected atrial fibrillation, I think it would be reasonable to go for a dual-chamber ICD. However, probably, as shown in this very good study by Professor Zabel, in the majority of patients, we might be safe to go for single-chamber ICD and do not need the second lead.
Okay, so the answer of the key question are number 5 for more than 2/3 of the audience. So they will go for the implantation of an ICD based on the guidelines criteria, which is very interesting. Is about 25% of the audience will choose number 1, and they will reassess the patient after additional 3 months. Because we know that in the guidelines we have to wait for 3 months, but some of the physicians, sometimes they prefer to wait a little bit for 3 additional months. So is it your current practice? Do you wait for 3 months after optimization of the medical treatment, or do you wait for a longer time?
So I think it's very important to base this on the history of the patient. In a patient who's on optimal medical therapy, and I would not wait much longer, but we will go into detail later when discussing that. However, if there's something to optimize, sure, I would say you should wait and give the patient a bit more time to improve under heart failure medication.
Okay, so we move on.
Okay, so indeed, as you see, this first question or the first possible answer, reassessing the ejection fraction after an additional 3 months, is quite intuitive. And for this patient, he has already shown improvements in symptoms and ejection fractions, so he might further improve beyond the indication criteria, as a relevant part of the audience noticed. As intuitive, however, as this might seem, I would not consider this to be a good option for this patient. First of all, we do know from the SCATHEF trial, which is shown in this slide, that even in patients who initially had an ejection fraction below 35%, and then during the study improved to above 35%, there was a clear signal of benefit from ICD use. Secondly, and you do see that on the second slide, we also know from population-based studies, the next slide, please. We also know from population-based studies that individuals with an ejection fraction below 40% who do not have an indication criterion for primary prevention ICD use, they do face a relevant risk of sudden cardiac death. And this risk does not disappear at the ejection fraction cutoff of 35%. Thirdly, and probably most importantly, we all do know that there's a certain variability in the measurement of the ejection fraction. So this patient who is on optimal medical heart failure therapy might very well have a worse ejection fraction at the next follow-up meeting, so that pushing back the decision to implant an ICD does not really solve the case, but only delays the case. On the next slide, you also see a very intriguing answer. What if we could use cardiac MRI or any another imaging modality or maybe a biomarker to identify a substrate indicative of a high arrhythmic risk in our patient and to improve risk-guided or provide risk-guided ICD implantation? On the next slide, you see that there are indeed several studies which have shown that markers such as the magnitude of myocardial scar are associated with arrhythmic events. However, there's yet no prospective randomized data which has shown that this approach indeed improves patient selection and outcomes, so that we should not use this strategy in our patient. On the next slide, you see the answer which I thought would cause the most attention, that the patient might be too old to benefit from an ICD. In fact, the Danish trial, which was discussed earlier and evaluated ICDs in non-ischemic heart failure patients, did indicate that younger patients might benefit from an ICD, whereas older patients seemed not to benefit. The cutoff indicated by this sub-analysis from the Danish study was between 60 and 65 years, so that our patients might indeed be too old to benefit from an ICD. Although in general, I think that we should carefully evaluate competing risks in all our patients, such as the risk to die from advanced heart failure or other comorbidities versus the risk to die from sudden cardiac death. And although age by itself might be a very valid surrogate marker of frailty, I personally do not see higher age per se as a limiting factor for this patient. Our patient has, despite his heart failure, an adequate activity in daily life and is not burdened with the magnitude of comorbidities. There is no indication at this moment of overt competing risk or frailty. Given that the data from the Danish trial derives from a subgroup analysis and that no RCT has yet shown that older patients do not benefit from primary prevention ICD use per se, we might keep the age cutoff in mind, but should not exclude patients from ICD use based on age alone. On the next slide, you see the fourth possible answer, which has also gained much traction recently. In this patient, the well-optimized heart failure medication might maybe reduce the risk of sudden cardiac death to such an extent that there is simply no need for an ICD. This statement is largely based on the observation that over the past 2 decades, the rate of sudden cardiac events in heart failure RCTs has markedly declined. Hence, as these past trials on primary prevention ICD use, such as SCATHEF and MADA2, were conducted in population not on up-to-date heart failure medication, their findings might simply no longer be applicable to our current heart failure patients. On the next slide, you see that this question ultimately has led us to conduct an analysis within our SWEDE-HF registry with the aim to evaluate and assess if primary prevention ICD use is still associated with mortality in patients with a contemporary heart failure treatment. And as you see in the next slide, this is not only important because our heart failure patients differ from those in past RCTs in regard to treatment, but they also tend to be older, tend to have more severe heart failure and more comorbidities. On the next slide, you see that these factors might also interfere with the expected benefit from ICD use, and we therefore assess the association between ICD use and mortality in the contemporary Swedish Heart Failure Registry, which is an ongoing healthcare quality and research study in which patients with clinician-judged heart failure are included. From this overall Swedish HF population, which is about 75,000 patients, we selected those, and you see that in the flowchart, who met the ESC criteria for primary prevention ICD use, namely a reduced ejection fraction, heart failure duration of 3 months or longer, and symptoms near class 2 or higher. We identified 16,702 patients who met these enrollment criteria, and our first major finding was that only about 10% of these patients were indeed treated with an ICD. Those patients who got the ICD were more likely younger, male, and more likely to receive better heart failure treatment as compared to patients who were not treated with an ICD. In this study population of the 16,702 patients, we then performed propensity score matching based on 31 clinically important variables, and were finally able to compare 1,305 patients treated with an ICD to an equal number of patients not treated with an ICD. On the next slide, you see that the baseline characteristics of the two groups in the matched study population were not only well balanced and matched, but the baseline characteristics also indicate that our study population quite much resembles a real-world heart failure population with a very high prevalence of comorbidities such as ischemic heart disease or atrial fibrillation, and also a very good use of heart failure treatments, as about a third of the patients were treated with a CRT. Almost all patients were treated with beta blockers or RAS inhibitors, and more than 50% were treated with MRAs. On the next slide, you see that within this matched study population, ICD use was associated with a significant reduction in the risk of 1-year all-cause mortality, with an absolute risk reduction of 4.2%. This association also persisted for the endpoint of 5-year all-cause mortality, although the magnitude of the association declined, showing an absolute risk reduction of only 2.1% for the 5-year endpoint. Overall, our findings occurred on top of a well-established guideline-recommended heart failure therapy, and as you see on the next slide, were very much consistent through all tested subgroups, which importantly included subgroups such as patients with ischemic heart disease versus those without ischemic heart disease, female versus male patient, and in the context of this case, older versus younger patients. The next slide, please. To summarize this, our data, as very much like the data from Professor Zabel, supports the current EC guideline recommendation for primary prevention ICD use, even in contemporary treated heart failure patients. And if we go back to the case of our 70-year-old patient with heart failure due to ischemic cardiomyopathy, who is symptomatic despite optimal medical therapy, you will see on the next slide that I personally do see a very clear indication for ICD use in these patients, as he met all guideline criteria, did not show any signs indicative of a markedly reduced life expectancy, and had no clear signs of competing risks. Next slide, please. To conclude, recent observational studies, ours and the one from Professor Zabel, do support the use of primary prevention ICD in up-to-date treated heart failure patients. In the future, we might be able to use risk-based approaches to improve patient selection. However, at the moment, we do not have randomized data backing this approach. The last and most important point probably is that competing risks are very important in the evaluation of patients for primary prevention ICD use. However, I would say that age alone is not necessarily linked to higher frailty and should, based on the current data, not be used as the sole exclusion criterion for ICD use. Thank you very much.
Thank you, Benedict, for this very important data. And I can see that the two registries found the same efficacy of ICD in heart failure patients with ischemic and non-ischemic cardiomyopathy with a reduction of mortality about 30%. If I look at your last sentence, there is several questions, and the questions are all the same. Will you implant an ICD in a patient who is 90 years old?
This is probably the most extreme case, the 99-year-old patient. I would say I would not do that, probably. I mean, there might be an outlier for any given question. So the fittest 99-year-old you could imagine might deserve treatment with an ICD. But I would say for the majority of all 99-year-old patients, this is too old. However, I think the age question is very important and interesting for patients in the gray zone. Is 70 years the cutoff, or maybe 75 years? With people getting older and older, maybe at one point we should go away from a very strict cutoff and really evaluate the patient on all his factors. Are there many comorbidities? How frail is the patient? How active is he in daily life? I think this is just much more important than age alone.
Thank you. Another question. In your survey, about only 10% of the patients who had indication for ICD were implanted with an ICD. Do you have some explanation about this underuse of ICD in your country?
We indeed do know that the low use of ICDs and devices, CRTs as well in Sweden, is a problem, which is much lower than, for example, in the US or other European countries, although it's not perfect in any country. And I can only speculate about this based on our results, but there are other studies who dig a bit deeper into that. The reason for this in Sweden might be that a lot of heart failure patients are not treated by cardiologists, but by general practitioners who might have a very different perception of risks and benefits of devices such as ICDs. So I would say that this might be a point to support primary treatment of heart failure patients by heart failure specialists or cardiologists. But this is only a speculation, obviously.
So that's a very interesting point, because that means that we do need to make some education to our colleagues who are not cardiologists. And this reinforces the fact that patients with heart failure should be taking in charge, should be managed by a heart team, including, of course, heart failure physician, nurses, echocardiographers, but also EP and surgeon for LVAD and so on. I have a question for both of you. The question came several times. It's a methodological question about what do you think about the application of a bimodal risk model in the patient selection to make the difference between sudden cardiac death and total mortality?
If I may go first, I think it can be a very useful thing. Because with an increasing mortality, you may also see different rates of sudden death, and the efficacy, the effectiveness of the defibrillator may change. So the ratio of total mortality and arrhythmic death is quite an important number to know. It's difficult to find out. It needs to be evaluated. There are models that need to be expanded, and also I'm not sure whether all colleagues do fully understand it. It also needs education, but the rate of arrhythmic death is very exciting to look at when indicating ICDs.
Benedict, do you have some comments about this question?
Oh, I absolutely agree with Professor Zabel here. Obviously, the ICD can only target arrhythmic events, not all-cause mortality per se. And to identify patients who will benefit from the risk reduction in sudden cardiac death is very important. I think at the moment, the risk scores which are available are probably not perfect to do so, but I would put some hope in the recently initiated PROPHET trial by Professor Hendricks from Leipzig, which will very much dig into this question to identify those patients beyond established markers who will benefit from an ICDs and those who will not benefit.
There is some other question about the role of echocardiography to assess the potential role of ventricular arrhythmia in patients with cardiomyopathy and especially the global longitudinal strain. Do you think that there is a role for this technique to help you to decide if you will implant or not an ICD in a patient?
Basically, again, yes. We're also doing a sub-study. We have collected echoes with specialized loops, not in all patients, but in many. And we have collected MRIs that have been done anyway. So we will look at this, and it's worth looking at it. Imaging is worth looking at it.
I have a question for Benedict now. If after the follow-up of the first device, you have a patient who had, at the end of the battery life, he has an improvement in left ventricular ejection fraction. Not a total normalization, but an improvement, I would say, with an ejection fraction about 40–45% in ischemic cardiomyopathy. Will you implant a second device or not?
A very good question. I think this is not only the question if the patient shows improvements in ejection fraction, but also for so many other parts. What if he's asymptomatic at a follow-up? Or what if he's much more severely diseased at the follow-up and would then maybe have very important comorbidities? So I think reassessing the indication for an ICD is very important at the given time points of device change. And probably in a patient who improved to well beyond 45% in like a very strict way, so that we have maybe multiple echoes showing that, so that it's not just one outlier, but that when we are very certain about an improvement that big, then I would probably opt to not reimplant the device. But this is very difficult to decide just based on one number. I think if the patient goes to normal, has no symptoms, then it's probably a decision not to implant.
I have another question for you because you included some patient with CRT in your registry. So what do you think about CRTP versus CRTD? In few words, if it's possible.
Few words. So we did not saw a difference there, and I honestly would expect that CRTD performs better than CRTP, because although there is definitely a remodeling effect from CRT, these patients might very well still have a risk of arrhythmic events, which then would be treated by an ICD. So if it's possible, I think I would go for CRT defibrillator as compared to pacemaker.
I think also we have to take into consideration the age, but also the comorbidities of the patient. I have a not so easy question for you, and there are several physicians who has a question. How do you explain that you have a significant benefit in non-ischemic cardiomyopathy in your two registries, which was not the finding from the Danish trial? So Benedict, do you want to start first?
Yeah, sure. So the first thing which I should say is that we used a very different definition of ischemic cardiomyopathy or non-ischemic cardiomyopathy than Danish. Indeed, we were unfortunately not able to assess the etiology of the cardiomyopathy because this variable is not available in our registry. So what we used instead is history or lack of history of ischemic heart disease, which might explain the difference. Another reason might be that the Danish study had a very longer follow-up. So maybe as compared to our study with a follow-up kept at 5 years, maybe this also explains the differences. But obviously it's very tricky to complain these two studies.
Thank you. Marcus, some comment?
I have two explanations for this kind of difference. Number one is we didn't have CRTs. CRTs were beneficial in Danish overall to lower mortality. And number two, even without CRTs, the average mortality, all-cause mortality in Eastern Europe and all European countries we enrolled was somewhat higher, 1.5-fold, let's say, sometimes a bit more, not more than double. But this may be enough to, especially in DCM, to explain some reduction of mortality. And other than that, it wasn't the aim of our study to compare ICM and DCM too much.
Thank you. Benedict, a question for you, because in your clinical cases, you propose the fact that we can wait a longer time than the classical 3 months. Do you use, if you have to wait after the optimization of the medical treatment, do you use the wearable cardioverter defibrillator in some patients?
This is very interesting. So I would say we do that for patients we deem at a very high risk of arrhythmic events. But in the majority of patients, this is certainly the exception to the rule. So we do use it, but we reserve this for very high-risk patients. So patients with, for example, a very malignant substrate in an MRI, although we do not have randomized data to back this, but in patients where we fear that there might be an event, we might use it, but it's not frequent.
Yeah, and unfortunately in France we don't have the indication for non-ischemic cardiomyopathy, but I think it's a good indication because as shown by the different registry and also the VEST trial, when you wait for a couple of months with the optimal medical treatment, about 50% of the patients have no more indication for ICD. So it could be a good way to wait in a safety model for these patients. I have another question about the remote monitoring. Marcus, do you think we have to use remote monitoring for every ICD patient?
Very good question, which I don't have the data for here. I think it's a useful thing. We used it in many of our study patients. It gives you the complete picture, but we also have seen data that follow-up works the traditional way. It's definitely more practical, and it gives you 100% of the information.
Thank you. Benedict, I have a little provocative question for you. It's come from the northern of Europe, close to your country. Do you think that we can use a ICD which did not provide you anti-tachycardia pacing? In another word, do you think that we can use a SQ ICD?
Sorry, could you repeat the question?
Yeah, the question was from the northern of Europe, a country just close Sweden. Do you think that we can use a device without ATP feature, anti-tachycardia pacing feature?
So again, I would say this depends on the patient. Subcutaneous ICDs have many advantages, especially in younger patients where we do not have the lead, do not have the infection risk or different risks. But I then, on the other side, think that in some patients, the ATP is very useful, especially in patients where we expect to have episodes which we can, like where we have many episodes which we can target by this. So it depends. But I would say in younger patients where we do not, where we have a higher lifetime risk, but not a risk of many episodes, in a shorter period of time, I think a subcutaneous ICD is very useful.
Thank you very much for this question. We have a lot of questions, but by question of time, we will have to conclude very soon. So your two registries were very well performed, and they did show the same result, a significant reduction in total mortality with ICD in the modern area of heart failure medical treatment. So now we are approaching the end of this webinar, and I would like to close this session by summarizing the key messages for your daily practice. First, the two registries did show a benefit of ICD on total mortality in ischemic or non-ischemic cardiomyopathy in the modern era of medical treatment. The two speakers agree that the decision has to be personalized according to the comorbidities, and probably imaging could be useful in the future. Benedict mentioned that the Horizon 2020 profit trial, led also by ESC and EHRA, will be very useful to clarify the gray zone we have today in the ICD. So I would like to thank Dr. Zabel, thank you Marcus, Dr. Schrag, thank you Benedict for your presentation and your participation to this very exciting webinar. This program was supported by Medtronic in the form of an educational grant. I just want to remind you that you will be able to watch this webinar on demand on the ESC website. I thank you very much for your attention, your participation, and I wish you a very pleasant evening. Goodbye.